I am Dr. Sharjeel and you are watching my YouTube channel, and today I would like to show you surgery of congenital cataract. You can see a central nuclear posterior subcapsular cataract, and we have made a main phaco-port, and now I would like to stain the anterior capsule. Make sure you put air bubble and then inject the dye to protect the corneal endothelium, and now remove it. Now as we are making it on Android phone, that's why you are unable to appreciate the red reflex, and now I have injected viscoelastic to deepen the anterior chamber and to dilate the pupil. Now in congenital cataracts, you should know that the rate limiting step is capsulorrhexis. The capsule is elastic and the capsulorrhexis can easily get radial. So what I do, I combine cystotome, a bent 1 cc needle tip with capsulorrhexis forceps. I have started capsulorrhexis with a cystotome, and when I saw that now it is going radial, I came out of the anterior chamber, put viscoelastic, and now I would like to grab it with a U-trotta. Here I have holded the anterior capsule, and now you can see again with the centripetal force it is again in my arc. So now again I came out when the anterior chamber got shallow, and now I am continuing it with cystotome. So you should know different gadgets to use while performing capsulorrhexis in children. You should put as much as viscoelastic as possible, and you should not shy away by using different gadgets, because you should have an aim that you have to make a round capsulorrhexis without nicks or cuts. Now the rest is easy in a congenital cataract. If you have got intact capsulorrhexis, you sometimes don't even need phaco emulsification, but here the center of this nucleus is a bit harder, so after aspirating the cortex and even dislodging that central part with a Simcoe irrigation aspiration cannula, I tried to aspirate it with the IA cannula, but in vain. So now I would like to put a phaco probe, and with the help of it easily emulsified the central nuclear part. Now take home messages in this video are two. Number one, round capsulorrhexis, and number two, sometimes there is a plaque, a thick plaque on the posterior capsule, and it seems to be its part as it is tightly adherent to it. Now you have three options in such thick fibrous plaques. Number one, leave it as such, implant foldable intraocular lens in the bag, especially if the patient is 4 to 5 years old, and later on perform YAG capsulotomy, because at this age and beyond that age patients are cooperative. Number 2, if the patient is younger than that age, then first try to manipulate that thick PCO-like plaque. My personal experience is that 90% of the time, when you continuously try to elevate it, manipulate that plaque, suck it with IA cannula, and there is continuous irrigation going on, the cells in that thick plaque, they swells, they imbibe fluid, elevate and detaches from the posterior capsule, and there is intact posterior capsule as well, like in this case. And number 3, if the patient is younger, 10% of the times the plaque will not separate whatever you do. And in order to prevent amblyopia, you can perform posterior capsulorrhexis with the cystotome all around the plaque. If vitreous phase remain intact, put IOL and case is done. If vitreous comes out, perform anterior vitrectomy and put IOL. So that's how you deal with a thick fibrous plaque or PC.